بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Dear colleagues, I'm Dr. Hanan Al-Rais, consultant rheumatologist and the president of Saudi Society for Rheumatology. On behalf of Saudi Society for Rheumatology, I would like to welcome you all in Best of ACR Convergence webinar. This year has been a year unlike any other. All of us have adapted changes and challenges we have never encountered previously. What did not change was that individuals were still diagnosed with rheumatic diseases, suffered, and some unfortunately lost their battle to the rheumatic disease. This is why sharing this year's significant scientific advances from the American College of Rheumatology Convergence meeting was a high priority for all of us in the planning committee of Saudi Society for Rheumatology. As such, I'm pleased to welcome you to the official Best of ACR Convergence Saudi Arabia program that will feature presentations by renewed international faculty as well as regional key opinion leaders. Over the next 4 days, we have planned an excellent presentations in both adult and pediatric rheumatology. Tonight's agenda features, in the adult session room, we will cover mainly rheumatoid arthritis and specifically about clinical treatment approach in adult rheumatoid arthritis by Professor Vivek Strand. And we have with us also Dr. Siham Al-Rashidi, which she will talk about the most relevant topic, timely topic, which is COVID-19 and rheumatic diseases. In the pediatric session room, we have Professor Karen Brand Onel. She is the chief of the Pediatric Rheumatology Hospital for Special Surgery at Cornell Medicine Hospital, who will discuss the 2020 ACR Juvenile Idiopathic Arthritis Guidelines. Tomorrow, in the adult session, we will hear from distinguished faculties from ACR faculties about evidence on myopathic rheumatic diseases, renal, systemic lupus erythematosus, as well as antiphospholipid syndrome. Leading the presentation and discussion in the pediatric session room tomorrow will be Dr. Mohammed Ahmed Mudaffar from King Abdulaziz University College Medicine. The session will include a novel topic of pediatric COVID-19, hyperinflammation, which will be presented by Dr. Ghada Al-Salami. On December 20, we will join together in one session room for update in non-renal systemic lupus erythematosus, primary Sjogren's syndrome, and systemic sclerosis, gout, as well as osteoarthritis. Our final sessions on December 21 will feature Professor Robert Inman, who will talk about spondyloarthropathy. In addition to that, to these official sessions, you will cordially invited to attend the industrial symposia being held by our supporter, as well as to visit our virtual exhibition hall, which will allow you to discuss treatment advances and connect with the representative of each company. On behalf of Saudi Society for Rheumatology, I would like to thank all our supporters. I would like to thank all distinguished speakers, chairpersons, and special thank to the organizing as well as scientific committees who did major work in the last month preparing for this Best of ACR Convergence 2020. For complete program with timing, please access Documents tab in the website as shown on screen. Finally, I would like to thank you for taking time out of your demanding schedules to attend our virtual program. I'm confident that your time invested in attendance will be rewarded with an advancement in your clinical skills and will improve patient care outcomes. I hope all of you stay well and we can be together in person for the next year, inshallah, in the official Best of ACR program. Thank you all. Now we'll start the adult rheumatology webinar. Tonight, the chairperson is Dr. Hussein Halabi. All of you know Dr. Hussein Halabi. He's a consultant rheumatologist at King Faisal Specialist Hospital from Jeddah. He is the president of Saudi Society between 2013 till 2016. Dr. Halabi is very active in publication, awareness, patient awareness mainly, as well as he is lecturer nationally as well as internationally. And the chair for you, Dr. Halabi, for the first presentation. Thank you.
Assalamu alaikum. Good evening, everyone. I would like to thank Dr. Reyes for the kind introduction. I would like also to thank the Saudi Society for Rheumatology for all the great work that they have done so far during the COVID pandemic. This is, of course, to bring the level and quality of education in rheumatology to the best standard. I would like to welcome you to the Best of ACR Convergence 2020. It's my pleasure to share this session, which will actually shed some highlights about all the updates in the management of rheumatoid arthritis and the approach in clinical and treatment of the same disease. Before we start with our first speaker, I would like just to present to you a few housekeeping points. Please note that on the screen, you can see that at the bottom of the platform, there are a number of circles. So the first circle to the left side is go to the main lobby. The next circle is if you want actually to join the adult session, go to the main conference room. And the fourth circle, if you want actually to join the pediatric rheumatology event, you go to the breakout room. Afterwards, at the end of each session, you will also, can I have the next slide, please? You will see that there are three options there. Please fill out the post-session survey. It's very important actually to fill it out in order to get your CME hours. And at the bottom of the screen, you can see that ask presenters a question. So we will receive those questions and we will, try to answer them as much as we can. So without any further ado, I would like actually to present the first speaker, Professor Vibeke Strand. Dr. Strand serves as a consultant in clinical research and regulatory affairs to the pharmaceutical and biotech companies. She has been a clinical rheumatologist for 40 years. She also has been served as an adjunct clinical professor, Division of Immunology and Rheumatology at Stanford University since September 2000. Since 1991, she's been consulted regarding translation of basic research into rational design of randomized controlled trials, analysis of their results, and presentation of novel products for approval to FDA and EMA. She has assisted in preparation of briefing documents, analysis, and data presentation for defense and NDA and BLA applications in RA, lupus, psoriatic arthritis, and other inflammatory arthritis, and the first and subsequent monoclonal antibody biosimilar. She has been an invited member of FDA Arthritis Advisory Committee meetings discussing guidance documents. Professor Strand will tell us about update on clinical approach and treatment of RA. Professor Strand, the mic is yours.
Hello, I'm Vibeke Strand, I'm a biopharmaceutical consultant and also an adjunct clinical professor in the Division of Immunology and Rheumatology at Stanford University in Palo Alto, California. It's very nice to join you, and I'm going to give you an update on the clinical approach and treatment of rheumatoid arthritis. So I am a consultant, and these are the sponsors to whom I consult. And the slides actually been adapted from the great debate at ACR, which I engaged with Dr. Weinblatt. So you will see my slides and his slides, and then a brief rebuttal, which wasn't part of the debate. And then I will ask you to think very strongly about how you would have voted. So there are a few slides that were omitted because of time, but otherwise it's a pretty complete presentation. So we'd like to think about outlining the benefits and risks of the JAK inhibitors, compare these with the TNF inhibitors, and then make your decision. Should JAK inhibitors be used before biologics after a patient has failed methotrexate? So here is the title slide. So one of the things we know about the JAKs is that they display different in vitro profiles with different selectivities. They modulate distinct cytokine pathways to different degrees and durations over 24 hours, but consistently they do not potently or continuously inhibit any individual cytokine signaling pathway, and certainly not over the full 24 hours, because all of them have a short half-life of around as much as 8 hours. It's unclear which cell types and what signaling pathways are affected at any given time. So we know what they do in vitro, but we really don't know specifically what they're doing in vivo. And despite having different selectivities, the clinical responses are really very similar across the class, certainly in rheumatoid arthritis, which has been studied the most. So if we look at JAK inhibitors plus methotrexate and compare them to adalimumab plus methotrexate in methotrexate IR-RA patients, we're looking at sustained ACR responses, looking at oral strategy, and these are ACR 20s. We see that tofacitinib 5 BID plus methotrexate is non-inferior to adalimumab plus methotrexate, both at month 6 and 12. And then we see in RA Beam that baricitinib 4 milligrams monotherapy is actually statistically superior to adalimumab 40 plus methotrexate at both months 3 and 12. And in Select Compare, upadacitinib 15 milligrams plus methotrexate is statistically superior as well at both month 3 and 18. And finally, filgotinib 100 and 200 milligrams with methotrexate are non-inferior to adalimumab 40 milligrams plus methotrexate at months 3 and 12. So very consistent patterns. And then if we look at sustained CDI remission, we see non-inferiority again, non-inferiority with baricitinib, superiority with upadacitinib 15, and superiority at month 3 with filgotinib 100 and 200 plus methotrexate. So all the JAKs studied to date in RA are effective and 3 are approved. They have early onset of benefit, including patient-reported outcomes, which we'll come to next, rapid improvements within 1 to 2 weeks, maximal at 3 months, regardless of the population. And the JAKs versus the biologic DMARDs in methotrexate IR patients also show non-inferiority or superiority. Baricitinib 4 superiority versus adalimumab plus methotrexate, upadacitinib 15 similarly, and then tofacitinib 5 and filgotinib 100 and 200 are non-inferior to adalimumab plus methotrexate. So as I said, we see ACR 20 responses as early as a week. Patient global pain HAC, duration of morning stiffness as early as a week. ACR 50 responses as early as 2 weeks, and patient global in pain are reduced as soon as 3 days. This is from the tofacitinib solo trial, and these are the patient-reported IVRS scores for patient global assessment of disease activity and pain. And notice the improvement already at 2.5 days, which continues out to 15 days. and then continues long-term over 6 months. So even though the improvement may be maximal at 3 months, there's persistent and even continued increases in improvements, and the placebo crossover then report similar improvements. So now I wanted to show you some patient-reported outcomes. This is from the tofacitinib SYNC trial, and this is the short form 36 or the SF36 that measures health-related quality of life. We're looking at the physical domains: physical function, role physical, bodily pain, general health perceptions. These are considered to be the physical domains. Vitality, social function, role, emotional, and mental health are considered the mental domains. Now, all 8 of these are calculated in the equations for the PCS and MCS, which are quite complicated, and thus I think it's easier to look at the individual domains to really know what the scores mean. Now, the domain scores range from 0 to 100, but hardly ever does anyone report a 100 score. So we have them here in integrals of 10, and each of these grid lines represents 10 points, which is twice MCID. MCID is 5 points. So now you're looking at the age and gender matched norms for this specific protocol population. And then you're seeing the baseline score for the whole protocol population. So you see the impact of rheumatoid arthritis across virtually all the domains, but particularly physical function, role physical, bodily pain. And then this is the improvement with placebo. And here now is the improvement with tofacitinib 5 BID, statistically significant versus placebo in 7 domains. And then with 10 BID, you could see numerically further improvements and statistical significance across all 8 domains. Now let's look at the percentage of patients who are reporting improvements greater than or equal to MCID at month 3. And we're looking at the HAC and the FACIT, SF36 PCS and MCS. And the normative scores or the improvements in HAC are greater than minus 0.22, for FACIT greater than 4, and for the PCS and MCS greater than or equal to 2.5. And as you can see here, about 54 to 74% of patients are reporting clinically meaningful improvements already at month 3. And thus we have the number needed to treat to result in such a nice improvement, and it ranges between 3.7 and 8.3. That means that anything less than or equal to about 10 patients is a very meaningful number needed to treat. Here's now upadacitinib next, and you're seeing the baseline and normative scores. Now you're seeing placebo improvements, and then those with upadacitinib 15, which is statistically significant 7 domains versus placebo. And finally, upadacitinib 30 is just a little bit better, but only statistically significant in 6 domains. And here now we're looking at the patients who report scores that meet or exceed normative values at baseline and then at week 12. So very few patients are reporting these kinds of scores at baseline, as we might expect. And only in the MCS scores are there roughly 30 to 40% of patients. And that's because we know our RA patients are robust and they tend to have high MCS scores. But now you're seeing the improvements at 3 months. And you could see large improvements, so that we're looking now at 42% who meet normative values for FACIT, and similarly something like 29 or 30% for the HAC. So very nice data. And this is that patients then feel as if they may not have rheumatoid arthritis, as they may feel and function normally. Now we have baricitinib and tofacitinib looking at FACIT fatigue. So this is the BEAM trial again, and it's 4 milligrams of baricitinib versus adalimumab. And you can see that these numbers are statistically different with baricitinib versus adalimumab all the way out to 24 weeks. And then we see TOFA, the standard trial, looking at both doses of tofacitinib versus adalimumab, and they're numerically better at all time points. And they result in number needed to treat of 4.1 and 4.9 versus adalimumab of 5.6, indicating the numerical difference. And now we have upadacitinib with the COMPARE trial. And again, we see very low baseline scores. This population seemed to have been more treatment experienced. Here, however, is the large improvements with placebo. And then we have the improvements with adalimumab 40, and then the improvements with upadacitinib 15, statistically significant versus placebo across all domains, and versus adalimumab in 6 domains. And now we have the percentage of patients who are reporting normative scores at baseline. Again, very few, with the exception of the WIS, which is the work instability score. And here, those patients who are reporting scores are not worried about losing their job because of their arthritis. And then we see the improvements at 3 months. Now we can see even the majority of patients receiving either adalimumab or upadacitinib no longer share that concern about losing their work. And then you can see the large improvements in the FACIT and the SF36 and HAC. So we know that the patient population is important. They're more responsive if it's earlier in the disease process, which is why we should think about starting a JAK after methotrexate failure. Furthermore, methotrexate IR patients generally have experienced great improvement with their first DMARD after experiencing this significant impact of disease. And so they are active, they're often working within or outside the home, and they have high expectations for control of their disease, and they want to feel and function normally. And this is attainable with the JAK inhibitors. Plus, they're convenient, they're oral, it's easy to travel with them. Patients are aware of these early improvements. The adherence is increased. Remission is much more likely and occurs earlier. They're clinically meaningful improvements, as I showed you, by 55 to 75% just at 3 months, and 11 to 50% report scores that meet or exceed normative values. As I again said, they're oral and convenient, and these 3-month changes are critical time points for the target of remission. And here you could see the remission scores at month 3 on the left and at month 6 on the right. You can see large percentages of patients with DAS-CRP improvements, remissions, even the percentage of patients who meet the very stringent Boolean, and as we can see also, up to 15 to 20%, 21% who have SDI and CDI remissions at 6 months. So the safety, well, they're oral agents, they have a short half-life. They generally have a similar profile across agents, similar to TNF inhibitors with a few notable exceptions. There is a higher incidence of zoster reactivation, and thus the recombinant adjuvanted vaccine is important. They have a less atherogenic lipid profile despite increases in HDL and LDL because cholesterol efflux capacity is increased when the CRP drops. The thromboembolic events are the latest concern, and they're considered a class effect by the FDA, but I think there is an argument against that. Finally, there are GI perforations, and they may be more common than with TNFs, but they're less common with than with tocilizumab. And the laboratory changes require monitoring, but typically they don't require either dose reduction or discontinuation. And we know the CPK increases reflect reversal of inflammation-induced inhibition of myoblast differentiation. And we know that the serum creatinine increases are generally idiosyncratic. So what about the VTEs? Well, we know that VTEs occur in RA at a higher incidence. And we just saw in the Swedish register at EULAR that the incidence is increased, particularly with higher disease activity. So patients with high disease activity have twice the incidence as those who are in low disease activity or remission. We also know there's a variable incidence of these events in trials. The majority of patients who've had these events had had a prior event. With baricitinib 4 milligrams, the incidence was 1.3 per 100 patient years, yet none occurred in the 2 milligram dose group. And in the extension studies, the incidence was 0.3. With upadacitinib 15 and 30, there was an increased incidence in phase 2, yet it was balanced versus adalimumab and methotrexate in phase 3. In TOFA, with both 5 and 10 milligrams, the incidence was very low in the trials, 0.1 per 100 patient years. However, then looking at those patients with cardiovascular risks at baseline, it increased with the tofa 10 milligram dose to 0.24. But when we now look at the open label safety trial, cardiovascular safety trial, here we see with the 10 milligram dose, it increased to 0.54 per 100 patient years, which certainly suggests a link to cardiovascular risk factors. We know that they are increased with COX-2s and non-steroidals and glucocorticoids, but importantly, there's no plausible mechanistic explanation identified for these as a class effect of JAKs. So in conclusion, I hope I've convinced you the JAK inhibitor class is an exciting development for rheumatology. They should be used early. Responses are better, very well established efficacy in RA, convenient, short half-life so that adverse events can often resolve over a short time frame. And we know what the risks are, and we know what we need to do for surveillance and also attention to VTEs, ATEs, and herpes zoster. So now I'm going to present another perspective, Dr. Weinblatt's perspective, where he thinks that JAK inhibitors should not be used before anti-TNF therapies in RA. And he reminds us that we have 5 approved TNF therapies. They all had large development programs, but actually none of them were as large as the JAK inhibitor programs. And we've now had clinical experience with them for 22 years. What are their safety issues? Of course, there's infections. There's a rare demyelinating syndrome. There can be hematologic toxicity or liver toxicity. Rarely there are lupus-like syndromes. Certainly there can be worsening of heart failure if already existing. And there's been some question about a link to non-melanoma skin cancers. Nonetheless, they're an important advance. They have impressive effects on disease activity, functional outcome, radiographic progression. They do work better when used in combination, and they allow reduction in non-steroidals, steroid doses, and it's also possible to taper them. The responses are quick, and they're generally well tolerated. So we know that both the TNFs and the JAKs are effective with similar clinical effects. The JAKs are typically non-inferior to monotherapy adalimumab or adalimumab plus methotrexate, but we also know that baricitinib and upadacitinib have shown to be superior. They work fast with improvement in PROs and radiographic effects, similar retention rates. So the questions: infection, VTE, reproductive issues, colonic perforations. Are we really worried about cancer risks and lab monitoring? So here's the incidence of herpes zoster across the tofacitinib trials over a period of 54 months. And you can see that it's fairly stable. And one of the things we know about the tofacitinib is that trials were conducted in Japan and South Korea. And thus we know that they have a higher incidence of zoster for a variety of reasons. And then we see that the hazard ratios are increased based on that location, but also smoking status, tofacitinib dose higher, glucocorticoid use at any dose. And finally, recently in Lancet Rheumatology, the serious infections with JAKs versus biologic DMARDs, this was a test across the Medicare and Optum and MarketScan databases. And what we see is that there is a higher hazard ratio for tofacitinib versus etanercept, versus abatacept, versus tocilizumab, and versus adalimumab, but lower than with infliximab. But again, it is associated with a higher incidence of zoster. And then if we look at the total DVT-PE incidence by analysis set, here we're looking again at baricitinib. We see that the majority of these events occur in the placebo-controlled first 24 weeks of the trials. And that they're associated with older age, heavier BMI, COX-2 use, and certainly the history of having had a previous one. So some questions: is there an increased risk of VTEs with JAKs? Is there a difference in risk among the drugs? Is there a dose event? What's the mechanism? What drugs should be avoided in patients who are receiving JAKs? What population should avoid JAKs? Should we use anticoagulation? And what about in other diseases? And so then I want to remind you that over 22 years of use, we found out that the TNF inhibitors are quite safe in pregnancy, whereas we know relatively little about the JAK inhibitors, as we've only had tofacitinib for 7 years. So we have to worry about colonic perforations with JAKs, but not TNFs. We already know that breastfeeding, not only and pregnancy, are much better, safer with TNFs. Lab monitoring, we don't really do as much for TNFs, if we do any. The dosing is daily for the JAKs, but remember, we can go to weekly or even every several months, particularly if we're tapering TNFs. We really don't have the answer for DVTs and PEs. And remember, biosimilar TNF inhibitors are a major cost savings. So in summary, there's equal efficacy among the compounds. There's dose flexibility with TNFs. There's a higher rate of zoster with the JAKs. We have the uncertainty regarding VTEs and PEs. We have to think about lab monitoring. We need to be concerned about pregnancy and lactation with JAKs. The choice is obvious. So now I'm going to present to you a brief rebuttal. So this is adjusted Kaplan-Meier plots for VTE risk with tofacitinib versus the TNFs in the Truven and Medicare databases, where tofacitinib represented about 6% of the use. And you can see that there's no statistical difference between these. And we've seen the recent report about the incidence of venous and arterial thromboembolic events in the tofacitinib rheumatoid arthritis, psoriasis, and psoriatic arthritis development programs based on whether patients had background cardiovascular risks. And I remind you that when we looked at that carefully, we see that it increased in the clinical development program from 0.1 to 0.24, but it was definitely increased in the cardiovascular safety study. What about serious infections? Well, looking at the trial data for each of these agents and tofacitinib at the time of the FDA approval meeting, we see that tofacitinib had an incidence per 100 patient years that was quite favorable to the other classes and definitely less than the combined incidence for the TNF inhibitors. And then if we look at baricitinib, we see again a similar incidence for serious infections, but an increased incidence with herpes zoster. And this is now a multi-cohort database, again, looking at the Truven and Medicare. And we see that the one difference is that tofacitinib does have an increased risk of herpes zoster against all of the biologics that we currently use. And we know that the zoster incidence is increased. With tofa is 3.9 per 100 patient years. With bari it's 3.3 per 100 years. And with upadacitinib it's 3.4 per 100 patient years. And the majority, however, are single dermatome, not disseminated, nor SAEs. And then we have a recent abstract from ACR from Skåne Hospital in Lund, Sweden, looking at 40 patients who are taking JAK inhibitors versus 20 healthy volunteer controls and giving them the new adjuvanted recombinant VZV vaccine, and then measuring responses by ELISA against the VZV glycoprotein E. And we can see that the controls, it was 100% positive responses, and in the patients, it was 75%. But there's further data pending that we'll see, T-cell responses, among others, to be analyzed. But overall, the vaccine was very well tolerated. There were no cases of zoster, and only 4 patients complained of worsening underlying disease. And this vaccine can be given even after the patient has started a JAK inhibitor or another immunomodulator. And then about pregnancies with tofacitinib. Well, the first citation is from the RA Psoriatic Arthritis and Psoriasis program. And overall, there were 45 pregnancies. There was a single congenital pulmonary artery stenosis. There were a majority of patients with live births, although some were lost to follow-up, and there were about 15 either spontaneous or medical abortions. So really a very safe profile, although obviously very preliminary. And then in the ulcerative colitis exposure, there were 15 pregnancies, and there were no deformities, there were no deaths. It resulted in predominantly normal pregnancy results in normal fetuses with 2 spontaneous abortions and 2 medical abortions. So I hope I've convinced you again that the JAK inhibitor class should be used early. And for all of these reasons, we get good results. And most importantly, the risks have been identified. The need for Shingrix vaccine, careful history, attention to risk factors for VTEs and ATEs, and surveillance for serious infections and malignancies, as we do in all of our patients. So I thank you for your time.
Okay, great. Welcome back, and thank you very much, Professor Strand, for this great presentation. A lot of information. We have a couple of questions. Actually, I will start with.
I've been asked to say something first. May I?
Sure. Yes, please. Go ahead.
So I'm Vibeke Strand, and on behalf of the ACR Partner Program, I'd like to welcome you to the Best of ACR meeting. This year is new, and the ACR Partner Program at Sister Partners offers to the sister associations, such as the Saudi Society of Rheumatology, the opportunity to share original presentations and invite renowned faculty to present a high-level snapshot of the 2020 ACR Convergence meeting. So it's specifically designed for the needs of the SSR membership, and I hope you will enjoy and learn from it. And thank you, Dr. Hussain.
Thank you very much. I will start actually with the first question. One of my fellows actually a couple of months ago asked me a question concerning, the management of rheumatoid arthritis in the last couple of years, and he said, "Could you give me your humble opinion about what has been done so far?" And I said, "I think it's the era of JAK inhibitors," and there has been actually a lot of light has been shed on the use of JAK inhibitors over the last 2-3 years. A lot of presentations, lots of lectures, a lot of promotions from the pharmaceuticals about the use of JAK. Even some of the pharmaceutical companies that they have developed anti-TNFs, now they are in favor of their JAK inhibitors over their anti-TNF. Now, don't you think with all of this promotion, the management of rheumatoid arthritis have actually led us to another pathway, as if we gonna forget all about the different biologics we have, and we are just concentrating more on the JAK inhibitors? What do you think?
Well, I think that that's true, but I think that Dr. Weinblatt's point about 22 years of experience with the TNFs and shorter time with the other biologics, but we know them well. So I still think they have a role. And I also think certain patients would rather have injections every 2 weeks or even as often as a month rather than having to take a pill. But I think it's sometimes a very hard decision on the part of patients. So it just makes it more important for joint decision making about what the patient should try.
Very good. I have a question for you. Would you use JAK inhibitors in somebody who had provoked thromboembolic disease, but failed most of the other modalities of treatment? So basically, the JAK inhibitors is your last chance.
I would do that, but I would give anticoagulation. Now, the issue is whether you would want to give an injectable one or whether you think an oral would be sufficient, but I definitely would use an anticoagulant.
And you would use anticoagulant at a therapeutic dose or prophylactic dose?
That's a good question, and I think that really depends on the patient. How long ago was the previous event? What type of event was it?
Great. I guess that's all what we have for this session. So I would like to thank you again, and
Thank you.
we're gonna see you in a bit. We are having right now. I would like actually to present my dear friend, Dr. Abdulaziz Al-Khalaf. يعني everybody knows Dr. Al-Khalaf. He's a consultant rheumatologist at King Khalid University in Riyadh. He's actually well known to most of us. He's interested in lupus and many other inflammatory arthritis. He has published several, papers in that specific area, and he will present actually Lilly Symposium. So, Dr. Al-Khalaf, the mic is yours. Thank you.
Assalamu alaikum. Masal khair. Good evening, everyone. It's my pleasure to present in the next 20 minutes this presentation about baricitinib and the management of rheumatoid arthritis. And I would like to thank Dr. Hanan Reyes as well. Dr. Hanan actually did a great effort, and everyone would like to thank Dr. Hanan for her effort and the society for this kind of I don't know how to say it, but it was a great mechanism during the COVID time where we had a lot of presentations where we kept ourselves updated in the era of COVID. And Bismillah, we'll start. So the program this presentation is sponsored by Lilly, and I have no conflict to interest to disclose. So let me just start with the first slide. So the JAK inhibitors actually since it started earlier in 2013 and then 2016 with most recent one about the system in 2018 as well. We had 3 so far approved medications, JAK inhibitors. And as you know, there is a need for effective treatment as well as a safe treatment for our rheumatoid arthritis patient. And JAK inhibitors represent an emerging once daily treatment for a patient who required such an oral medication. And these targeted synthetic DMARDs are being recommended as a second line of therapy alongside well-established biologic DMARDs. JAK inhibitors have been proven and through head-to-head trial to be effective and safe as a treatment and it was compared to the first and second line of standard of care biologic DMARDs. There are, as I mentioned, 3 approved medication. And baricitinib is a selective and reversible JAK1 and JAK2 inhibitors with a different mechanism from the standard of care medication. Okay, so it's an oral medication which is very selective to JAK1 and JAK2 with less potency toward JAK3 and JAK and tyrokinase 2. So it's administered in 2 different doses, 2 milligrams and 4 milligrams once daily. It peaks in the plasma in 1 hour time post-dose and stay for up to 2-3 days, and the bioavailability up to 80%. The half-life of it is around 12 hours, and it's excreted through the urine by around 70%. And the recommended dose is 2 milligrams once daily in patient who's taking other medication that can be inhibited by the JAK inhibitors. So there are many trials of baricitinib where the first one was an MTX naive patient and being used as a monotherapy, which I really like to consider it in my patients where they suffer from using of methotrexate because of the side effects that's been happening. And we know that up to 40 to 60% of patients who is using methotrexate, they may drop out of methotrexate because of the safety. And then another trial with the head-to-head trial in adalimumab versus baricitinib as a combo therapy, as well as the RA build trial where they compared actually to placebo with a combo, as well as the TNF inadequate responders after failing in a TNF. And we had the most recent one is the long-term trial, which is the RA Beyond, up to 7 years of duration, which showed us some of the safety profile of the baricitinib. So the baricitinib, as been studied, it has superiority to the standard of care. Its consistent and durable efficacy across most of RA groups. It has rapid onset to be effective, as you know, slow structural damage progression being also proved, and has versatility in the dosing and treatment switch as well, and manageable as of today with the safety profile that we have so far from the long-term trial. So baricitinib, as you know, is superior to adalimumab in patients with MTX inadequate responders, and that's what showed in RA Beam study. And this is where we used to say that most of the biologics therapy, the ACR 20 is 60, and baricitinib came to up to 70%. So this is the things that we actually say today. We used to say to our patients that all biologics are equal, but in the presence of JAK inhibitors, especially baricitinib and obatitinib, maybe it came to be a superior. So the earlier effectiveness of the baricitinib and the sustainability of the DAS28 response shows in this trial when you compare it to adalimumab as well. So here, baricitinib showed statistically significance in the ACR response versus adalimumab. In the ACR 2070 to 60, when the ACR 50 was 40 to 35, and the ACR 70 was 20 in comparison to adalimumab, which is around 15%. So again, we need to consider this in mind when we discuss with our patients the superiority of the kind of medication. Here as well, the baricitinib showed significant improvement in RA disease activity versus adalimumab that's maintained in methotrexate inadequate responders up to 52 weeks. This is where we see nowadays most of the head-to-head trials comparing JAK inhibitors with anti-TNF, which showed superiority. And especially when we consider the pain for our patients and the response to their the absolute pain improvement was higher among patients of baricitinib in comparison to adalimumab, as well as the percentage of pain improvement from the baseline was superior of baricitinib group in comparison to adalimumab. Sorry. So here the median time to show a 50% improvement in baricitinib group was much quicker, as even 50% time needs less to reach the pain improvement in comparison to adalimumab, and the median time to 70% improvement was reached up to 12 weeks in comparison to patients who received adalimumab, which they required up to 20 weeks. The change on the structural damage was almost comparable to adalimumab. So it was non-inferiority, where we need to consider this in our patient as well. So there is disease activity and remission in up to 3 years in methotrexate inadequate responders treated with baricitinib was achieved, and the SDI were less than 11 actually among patients with baricitinib, as well as the SDI where it was less than 3.3, which is put them in remission. So always when we need to consider JAK inhibitors, we should look to the data, which showed really significant improvement among those trials. So the most important for all rheumatologists, the safety profile, which were actually kinds of comparable to other biologic therapy. However, in patients, as we know that there is a risk of herpes zoster among patients who is using JAK inhibitors, which was higher in comparison to placebo group. The risk of thrombosis, as we know that there are increased risk of thrombosis. However, in RA groups, actually patients, they do have this kind of risk even without using the baricitinib. So the serious infection by the safety analysis, it was almost comparable to the placebo group, and all bari group were 2.8 the incidence rate per 100 patients per year. So this is again helps us in considering baricitinib as one of the modality, even maybe the first line of therapy in patients who's reluctant to start DMARS therapy or other biologic therapy. In herpes zoster, the risk, we know that there is a risk of herpes zoster among patients who's using JAK inhibitors, and it's actually comparable to other JAK inhibitors so far. So just wait. Here we have the herpes zoster among all RRE patient who's using baricitinib was 1.9 or a 3.3 incidence rate per 100 patients per year, which is also comparable to other JAK inhibitors. And we need to consider patients, the age group, the comorbidities that putting them at risk, higher risk for herpes zoster when you use JAK inhibitors. So we know that there is a risk of DVT or VTE among all JAK inhibitors, but we know that RA patients, they do have risk 2 to 3 times in comparison to the non-RA patients. So again, so as Dr. Vivian said, that there is a possibility of considering some patients of anticoagulation prophylactic maybe dose in such a group. So the incidence rates of VTE among patients with RA from 2 data it was showing there is actually a risk among all RA patients. And if you see the among all the the synthetic group of the targeted synthetic group of the DMARS, the JAK inhibitors, in comparison to the conventional DMARS as well as the biologic DMARS, were almost similar to each other. So, however, still there is a higher risk among JAK inhibitors to develop DVT. And as I said before, so we need to categorize our patients based on their risk of developing thrombosis. So all bari group actually in RA in comparison to placebo, there is mild risk of increasing of VTE, and the baricitinib dose response, if we want to compare 2 to 4 milligrams, were almost similar. So there is no even risk higher among 4 milligrams group in comparison to people who's using 2 milligrams group. So in this slide, the patients who had VTE, either pulmonary embolism or DVT, were actually having a lot of comorbidities and previous history of DVT, and the requirement of starting anticoagulation was different between those 6 patients. So some of them, they need to continue the anticoagulation treatment since they developed the DVT, but in fact they continue the baricitinib once they started the anticoagulation later on. So I have just 2 cases that I like to present among 2 of my patients where we always see such similar cases. So I had a lady who was 25-year-old female. She was a single, not a smoker, and she was a software developer. She was diagnosed to have seropositive rheumatoid in September 2018 with symmetrical polyarthritis and positive serology in form of rheumatoid factor and anti-CCP. Her DAS is 28 ESR was 5.97 with 6 tender joints, 4 swollen joints, and her patient global was 8 that time, and her ESR was 65. The X-ray at the time of diagnosis didn't show any erosion, so she was given intramuscular dipomedrol 120 milligrams with initiation of methotrexate with escalation to 20 milligrams in 4 weeks' time. The 3 months follow-up patient felt better, but still her right knee was swollen and she had mild tenderness. And her DAS 28 ESR was 4.14, which showed mild improvement. Another intra-articular injection was given to the right knee of 80 milligrams as she had 1 single joint swollen. Patient was reassessed in 4 weeks' time. Her right knee better, but her small joints of the hand are not good enough, especially with the morning stiffness, and that she feels some side effects in form of hair loss due to the methotrexate usage. Her DAS 28 that time was 4.28. Actually, I discussed with the patient a way that she likes to be treated, and I asked her if she likes to be started on Olumiant as a JAK inhibitor, and she didn't like to be on any injection, especially I was considering her for anti-TNF initially. So she was seen back after a month of starting Olumiant 4 milligrams, where she felt better. Her stiffness, still she had some mild stiffness in the morning, but overall she had DAS 28 of ESR in 3 months' time. After reassessing her, she didn't show any active synovitis and she was actually in remission. So patient wondered if she can stop the methotrexate, and I started actually withdrawing the methotrexate gradual by 2.5 milligrams every month. And her last visit was in September 2020. She felt well, very well actually, and she was off of methotrexate, and her DAS 28 ESR was 2.4, which put her in remission. So again, this is where I love to consider my patients to be in monotherapy rather than combo therapy, especially with the side effects of methotrexate. So another case where I had 40 years old female, a married woman, with a housewife. She's not a smoker, diagnosed to have rheumatoid since 2002 actually. She had a long-standing rheumatoid arthritis, and she did well actually initially on etanercept. Eventually, she had an active disease where she was switched in multiple biologic therapy, Humira, where she had a primary failure, infliximab, a primary failure, tocilizumab, she had some response to it up to 6 months, and then she failed. Abatacept again switched by her primary rheumatologist, and then she failed. So I saw her the first time in October 2019, and she has been suffering of pain and swelling of both hands, with already erosive changes in form of ulnar deviation, swan neck deformities. So in methotrexate, that time she was on 15 milligrams, prednisone about 10 milligrams, abatacept injection. So her DAS 28 ESR, it was 5.54, which put her in high disease activity. She had some complications in form of anemia with the thrombocytosis, and her LFT renal profile were normal. So the patient was advised to be given rituximab, but she did not like to be admitted to the hospital to get an IV infusion. So Olumiant offered for this patient and started. Her follow-up after 3 months showed improvement in patient global 4/8, and her ESR started to drop with a normalization of her platelet, but she was still anemic, and her DAS 28 was 4.77. A follow-up after 6 months, she started to show some improvement, and her hemoglobin actually started to improve from 9.9 to 11, with DAS of 28, ESR was 3.64. So the follow-up after 9 months, she actually felt better. However, she was still having kinds of disease activity if we consider her with 1 tender joints and no swollen joints. So again, maybe we need to consider such response and good response in patients who had long-standing rheumatoid arthritis with multiple failure to many biologic therapy, and lately she had good response to Olumiant. So baricitinib demonstrated rapid response and greater improvement in disease activity measures, higher response rate and low disease activity and remission, as well as significant reduction in structural joints damage and symptoms control compared to the current standard of care. Baricitinib is the one of the first actually JAK inhibitors demonstrate superiority to adalimumab with the background usage of methotrexate. The onset of effect start as early as 1 week, and achieved outcomes, including low disease activity over the long term, are maintained. So baricitinib is the only JAK inhibitors with 2 approved dosing options so far. The incidence rate of VTE among RA patients was shown to be 2 to 3 times higher than rate of non-RA patients, and its relation with JAK inhibitors needs further studies to be clarified. And I would like to thank the organizing committee again, and thank you so much.
Thank you, Dr. Abdulaziz, for excellent presentation as usual, and thank you for your support to the society. Now back to this satellite symposium, would like to thank Lily for supporting also the society and sharing in Best of ACR as a platinum support. So we have a few questions here so far. They said, what is your opinion in a patient who got herpes zoster infection and he need JAK inhibitor? So did you give such a patient if he failed other medication and he's post herpes zoster infection?
Post herpes zoster?
Yep. Is it contraindicated?
No, actually it's not contraindicated, but in fact we need to tell the patients that they may have a risk again to develop. If we get the vaccine of varicella zoster, the killed one, maybe to be considered in such a group, and they have to understand that there is a chance of developing another attack of zoster.
Yeah, and especially we can give the herpes zoster during while taking even the JAK inhibitor. So it's not a fully contraindicated, but any specific JAK you will choose. So suppose you have a patient with positive. This is the question. You have any selectivity or no selectivity?
To be honest, as of today, the availability is very important. Whatever is available of JAK inhibitors has to be given to the patient. Among the 3 baricitinib, among the 3 JAK inhibitors, I think most of them are non-inferior to each other, and we don't have yet head-to-head trial. However, the baricitinib and the upadacitinib maybe shows some benefits and outcomes in comparison to tofacitinib.
Yeah. And here they said, what is the best JAK inhibitors for management of rheumatoid arthritis with positive antiphospholipid antibodies as beta-2 glycoprotein?
So far, we don't have any data to say that we need to screen or we need to consider such patients for JAK inhibitors. So as of today, I have no answer for this question.
Okay. So did you recommend to screen for antiphospholipid syndrome? You mentioned there is no consensus so far.
Yes.
Usually we just ask question about previous thrombosis and so on, and better to avoid other thrombogenic medication like oral contraceptive and so on. And they mentioned if it is positive, you will start aspirin. So any suggestion? I mean, if the patient failed the other, usually because we know that for the time being, not all hospital they have JAK, and most of them they are using it if failed other. But suppose the patient that need JAK inhibitor, do you recommend giving aspirin or anticoagulant?
Well, let me clarify this. And so among patients who was having antiphospholipid antibodies with no previous history of thrombosis, it's still controversy. However, putting patients on aspirin with the long-term side effects has to be discussed with the patient. Especially, I would consider aspirin maybe for people who's having triple antibody, where maybe they have an association with lupus. But putting them in anticoagulation in the presence of antibodies only is not maybe fair as of today. So it's still a controversy, but maybe we can discuss this with the patient, putting them on aspirin if they do have a triple positive antibody.
Yes, and usually better to avoid at the time being because we don't have consensus. So better to avoid JAK if patient have positive antiphospholipid or history of thrombosis. So we'll try to have another alternative. If not, then you consider the patient as a whole, and we'll see. Another question, is JAK safe in patients with hepatitis B?
So far, the hepatitis B patients, where we need to consider them for a prophylactic, where among patients who is having B cell depletion therapy, especially rituximab, or using higher dose of steroid. And this came from the American College of Gastroenterology, where those patients are really high risk. As of today, JAK inhibitors can be given, and you can consider, as we consider all our patients on biologic therapy, if they do have hepatitis core IgG positive.
So where you put JAK inhibitor now in the management after the release of ACR 2020 in the management of rheumatoid arthritis?
Well, it comes as a first line. This is, to be honest. So now we do have superiority data. We have patients who are in favor of oral rather than injection, where we need to consider JAK inhibitors as a first line.
Yeah. So far about, do you have any experience with pregnancy and
لا.
JAK?
هذه لا. No.
Actually, I have one patient. She gets pregnant while she's on TOFA. Actually, though important, she's around 30 years old, and she came 3 months pregnant while she's on TOFA. So we just hold it, and she continued. She was fine, and she delivered a normal baby. And as mentioned in the previous presentation, there is a data about 40 patients where they get pregnant and they are fine, but still. Okay, so far we are on time. Thanks again, Dr. Abdelaziz, for your excellent presentation and discussion. Thank you, Lily, for your support to the society. And we are coming to the end, and we leave the microphone for Dr. Hussein. Thank you.
Thank you very much, Dr. Hanan. And we're back actually to our update sessions. So Professor Strand, she will talk to us about the new ACR recommendations for the management of rheumatoid arthritis. Professor Strand, the mic is yours.
Hello, this is Vibeke Strand again, and I'm going to present to you the brand new ACR recommendations for the management of rheumatoid arthritis. Have you seen my disclosures? And so this is an acknowledgement to Brian England, Leanna Frankel, and Stanley Cohen, whose slides we adapted from presentations at ACR. The learning objectives: understand the new treatment guidelines for RA patients who are DMARD naive with moderate to high disease activity, DMARD naive with low disease activity, and administration of methotrexate. To outline new treatment guidelines for patients who are not at treatment target, and also tapering. And then to list those special patient populations for which recommendations are specifically being made. So this is the draft ACR 2020 pharmacologic treatment recommendations for RA. The treatment guidelines are produced to support high quality clinical care. The guidelines are regularly updated, and this last one was in 2015. And since then, sirolimus, baricitinib, and upadacitinib have been approved. And so now these will be coming out in publication. But this is the most detailed outline we have of them before the publication. So the scope of the guideline includes treatment with conventional synthetic DMARDs, biologic DMARDs, targeted synthetic DMARDs, and glucocorticoids, initial treatment and treatment modifications, tapering of DMARDs, and treatment with these therapies in high-risk populations. What's not included are recommendations regarding vaccination, non-pharmacologic therapies, pre-treatment screening and monitoring, because they were covered in 2015, perioperative management, and reproductive health. So the outcomes that are critical, of course, are disease activity and ACR responses, tapering, flare and regaining target, important physical function, radiographic progression, and health-related quality of life and other patient-reported outcomes. And the costs have been estimated from Lexicomp, and existing cost-effectiveness studies are included with the evidence report, which we do not have yet. So here's the overview, as I mentioned to you before. And so we'll go over them one by one. For DMARD naive patients with moderate to high disease activity, methotrexate is strongly recommended for monotherapy over hydroxychloroquine or sulfasalazine, and is conditionally recommended over leflunomide. And I just want to mention to you that neither hydroxychloroquine nor sulfasalazine have been demonstrated to inhibit radiographic progression. Sulfasalazine only in a 6-month period of time in a comparison to leflunomide. And methotrexate is strongly recommended over biologic or targeted synthetic DMARD monotherapy as the first DMARD. In DMARD naive, again, with moderate to high disease activity, should you use monotherapy or combination? Well, methotrexate, again, monotherapy is strongly recommended over hydroxychloroquine or sulfasalazine. It's conditionally recommended over CS DMARDs, either dual or triple therapy, or TNFs plus methotrexate. And it's strongly recommended over methotrexate and non-TNF biologics or targeted synthetic DMARDs. What about DMARD naive with moderate disease activity and glucocorticoids? Well, DMARDs without short-term glucocorticoids is conditionally recommended over DMARD plus short-term glucocorticoids, but we're talking about less than 3 months. DMARDs without longer-term, more than 3 months, glucocorticoids, strongly recommended over DMARD plus longer-term glucocorticoids. So we can see that even in low doses, glucocorticoids are falling out of favor, even for short-term use. And what about the DMARD naive with low disease activity? Here, hydroxychloroquine is conditionally recommended over other conventional DMARDs because of its safety. Sulfasalazine is conditionally recommended over methotrexate, and methotrexate is conditionally recommended over leflunomide. But in fact, none of these have strong recommendations because there's no evidence to support recommendations in terms of the administration of methotrexate. When starting, oral is conditionally recommended over sub-Q. If not tolerating oral, then split the dose or move to sub-Q or increase the concomitant folic acid, all of which are conditionally recommended over switching to another DMARD. If the patient's not at target on oral methotrexate, switch to sub-Q is conditionally recommended over adding or switching to a new DMARD. For patients not at target, treat to target is strongly recommended over usual care if the patient's biologic and targeted synthetic DMARD naive. It's also conditionally recommended over usual care if they are incomplete responders to greater than or equal to 1 biologic or TS DMARD. And minimal initial treatment goals should be of low disease activity, conditionally recommended over remission. Again, for patients not at target, what about glucocorticoids? It's helpful to add glucocorticoids to remain at target, and if they are on them, then you might consider adding or switching DMARDs over continuing the glucocorticoids. If they're on DMARDs and not on target, then add or switch to DMARDs plus or minus intra-articular glucocorticoids, which are conditionally recommended over intra-articular glucocorticoids alone. Also, for patients not at target, modification of DMARDs. If they're on maximally tolerated doses of methotrexate, consider adding a biologic or a targeted synthetic DMARD, which is conditionally recommended over triple therapy. If they're on a biologic or a targeted synthetic DMARD, switch to a biologic or different targeted synthetic DMARD is conditionally recommended. What about tapering? Well, tapering is considered if a patient's been at target for at least 6 months. And actually, the conditional recommendation is continue all the DMARDs at their current doses over attempts at dose reduction. However, dose reduction can be conditionally recommended over gradual discontinuation. In other words, it's much better to increase the interval rather than gradually reducing the dose and stopping. Gradual discontinuation is conditionally recommended over abruptly stopping as well. And in patients who want to discontinue, if they're on triple therapy, then gradually discontinuing sulfasalazine is conditionally recommended over hydroxychloroquine. If they're on methotrexate plus a biologic or a targeted synthetic DMARD, gradually discontinuing the methotrexate is conditionally recommended. And now we're moving on to the specific populations. So we have those populations with subcutaneous nodules and moderate to high disease activity. Methotrexate is still conditionally recommended over alternative DMARDs, although we know that methotrexate may be implicated in the nodule formation. If they're on methotrexate with progressive nodules, then they need to be switched to a non-methotrexate DMARD as a conditional recommendation. In patients with pulmonary disease and moderate to high disease activity, and this could be either incidental, mild and stable airway, or parenchymal disease, methotrexate is conditionally recommended over other DMARDs, as we have the most experience with it. Heart failure. Well, the New York heart association, classification of 3 or 4, and incomplete response to a conventional synthetic DMARD, patients should consider a non-TNF biologic or a targeted synthetic DMARD. They are conditionally recommended over a TNF inhibitor because of the known effects of TNF inhibitors on existing heart failure. If they're on a TNF inhibitor and they develop heart failure, then they should be switched to a non-TNF biologic or targeted synthetic DMARD as a conditional recommendation over continuing the TNF. Lymphoproliferative disorders with moderate to high disease activity. Well, if they've had previous lymphoproliferative disease and thus they're receiving rituximab, then the rituximab is conditionally recommended, and overall is conditionally recommended over other biologic or targeted synthetic DMARDs. And we do know, of course, that lymphoproliferative disorders appear to be most related to persistent high disease activity. Hepatitis B, prophylactic antiviral treatment is strongly recommended if they're anti-hepatitis core antigen positive, antibody positive, hepatitis core antibody positive, and then starting rituximab, even if they're surface antigen negative. And if they're surface antigen positive, starting any biologic or TS DMARD. Frequent monitoring is conditionally recommended, especially for anti-hepatitis core antibody and hepatitis surface antigen negative who are starting a non-rituximab biologic or a targeted synthetic DMARD. And what about NASH, non-alcoholic fatty liver disease? If they're DMARD naive with moderate to high disease activity, normal liver enzymes and normal liver function tests, and no advanced fibrosis, methotrexate is conditionally recommended over other DMARDs. If they have persistent hypogammaglobulinemia without infection, and typically then they're on rituximab and they're at treatment target, continuing rituximab is conditionally recommended over switching to a different biologic or targeted synthetic DMARD. Previous serious infection within the last 12 months, moderate to high disease activity, add or switch DMARDs is conditionally recommended over starting and increasing glucocorticoids. And if they have moderate to high disease activity, despite CS-DMARD monotherapy, then adding CS-DMARDs is conditionally recommended over starting a biologic or a targeted synthetic DMARD. Non-tuberculous mycobacterial lung disease. In all scenarios, decreasing glucocorticoids to the lowest possible dose is conditionally recommended over continuing the same dose. When they have moderate to high disease activity, despite treatment with a CS-DMARD monotherapy, they're conditionally recommended to be continued over a biologic or a targeted synthetic DMARD. And with moderate to high disease activity, despite CS-DMARDs, abatacept is conditionally recommended over other biologic or targeted synthetic DMARDs because of the perceived better safety profile. So before we look at the application of the RA guidelines in clinical practice, I want to remind you that almost all of those recommendations were conditional because they do not have sufficient data to make the recommendation stronger. So just to remind you that the guidelines and recommendations were developed and endorsed by the ACR, and they are intended to provide general guidance for commonly encountered clinical scenarios. The recommendations don't dictate the care for the individual patient. The ACR considers adherence to the recommendations to be voluntary, with the ultimate determination to be made by the clinicians in light of each patient's individual circumstances. So we'll start with a 55-year-old female with 3-month history of joint tenderness, swelling, morning stiffness of 2 hours, and ongoing fatigue. Otherwise healthy, except that she has hypertension and a history of smoking. She's had modest relief with over-the-counter nonsteroidals. She was seen by her primary care physician with a SED rate of 40 and a CRP of 1.5. She was referred to rheumatology with 6 tenders, 6 swollen joints on exam, and a CDI of 21. Her rheumatoid factor was positive at 60 international units, her CCP at 250 units. She had no erosions on X-ray. But what are the treatment options? DMARD naive with moderate to high disease activity. So again, DMARD monotherapy with methotrexate strongly recommended over hydroxychloroquine or sulfasalazine, conditionally over leflunomide, and strongly recommended over biologic or TS DMARD. How about monotherapy versus combination? Monotherapy conditionally recommended and strongly recommended over methotrexate and a non-TNF biologic or a targeted synthetic DMARD. So methotrexate is conditionally recommended over leflunomide due to evidence supporting its extensive use as an anchor drug, as well as its lower cost and dose flexibility. Strongly recommended over tocilizumab and JAK inhibitor monotherapy, really because of the cost and lack of regulatory approval for biologic DMARDs or targeted synthetic DMARDs in CS DMARD naive patients. And methotrexate is conditionally recommended over combination CS DMARD due to higher burden and cost of multiple medications. Despite the data that suggests greater improvement with combination RX, there is some question about those trials in terms of the statistical analysis. Here now is a 60-year-old female who's seropositive RA with disease of 3 years duration. Previously, she received etanercept and methotrexate with initial benefit and being at low disease activity, but she flared and was switched to tofacitinib 11 milligrams daily with methotrexate 20 milligrams weekly. She had an excellent response and has been in CDI remission for 6 months. She wants to know if she could discontinue either or both treatments due to a dramatic improvement and preferably ask for methotrexate because of mild alopecia. So the recommendation in patients in low disease activity or remission for at least 6 months, gradual discontinuation of methotrexate is conditionally recommended over discontinuing a biologic or TS DMARD. And the recommendations presume that the patient will remain on at least 1 DMARD at a therapeutic dose. The rationale is the gradual discontinuation of methotrexate recommended, as these therapies, the biologics and TS DMARDs, are usually already added to methotrexate in adequate responders to achieve disease control. And withdrawal of these therapies are more likely to result again in loss of control. But the panel acknowledges that methotrexate gradual discontinuation may not be possible in certain patients on certain monoclonal antibodies. Here now is a 64-year-old female with active seropositive RA of 4 years duration. Initial CDI 28, and she was treated with 25 milligrams of methotrexate orally, subsequently sub-Q, with improvement from 28 to 12 in the CDI over 5 months. Due to active disease, etanercept 50 milligrams a week was initiated with excellent response by 12 weeks, with a CDI now of 4. But at month 12, she flares and her CDI is now 18. So what is the next step in treatment? So we're talking about patients taking a bio-DMARD or targeted synthetic DMARD who are not at treatment target. And a switch to a bio-DMARD or TS DMARD of a different class is conditionally recommended over a switch to bio-DMARD or TS-DMARD belonging to the same class, as we've had at least open label trials that have confirmed that you respond better to a different class of therapies once you've failed, for instance, a TNF inhibitor. But the recommendation is based on low certainty evidence, suggesting greater improvement in drug survival among patients switching classes. And the conditional recommendation is because patient and physician preferences are likely to vary based on prior experiences with specific DMARDs. So the overall summary and key points: the guidelines address treatment with conventional synthetic, biologic, and targeted synthetic DMARDs, as well as glucocorticoids. They include initial treatment and treatment modifications, tapering of DMARDs, and treatment with these therapies in high-risk populations. The high-risk populations include subacute nodules, pulmonary disease, heart failure, lymphoproliferative disease, hepatitis B, NASH, persistent hypogammaglobulinemia after rituximab, previous serious infections, and non-tuberculosis mycobacterial lung disease. Outcomes that are judged as critical include disease activity, ACR responses, and tapering, important physical function, X-ray progression, health-related quality of life, and other PROs, and cost. Existing cost effectiveness studies will be included with the evidence report. So on that note, I'm going to conclude, and thank you very much for your time.
Thank you very much, Professor Strand. That was actually an excellent overview of the current recommendation of the ACR in the management of RA. So the first question, if somebody actually on JAK inhibitor monotherapy, would you consider tapering, and what is the risk actually of relapse in those patients? Professor Strand, you are muted. Could you unmute yourself, please?
Dr. Strand, you can refresh your page and it will be fixed. Thank you.
Refresh the page. Okay, I think we're just gonna give her a minute or so. So okay, we're back.
Yes, so very interesting question, because we don't have much data about tapering. We have seen the fact that if you use a JAK inhibitor with methotrexate, you can successfully taper off the methotrexate, and patients do just as well. But the idea of taking a short-acting agent with a half-life of about 6 to 8 hours on an average among the three we have, and then trying to taper, I think could be very risky, particularly since only the low dose is approved in the United States, and in Europe, sometimes there's the higher dose and sometimes not. So I think without more data, I wouldn't be very comfortable about it. But the nice thing is we know that they have such a short half-life and they work so fast that we almost know within weeks whether they're effective or not.
Sure. What's your advice concerning using of JAK inhibitor in somebody with interstitial lung disease?
Well, I don't have a major concern about that because I think they've all been tested in an extensive number of patients for clinical trials. Now, obviously, we have one that's been around for 7, 8 years in the US, tofacitinib, and the others are much newer. But I'm not particularly aware that there should be a problem. And given their short half-life and the fact that adverse events often resolve quite quickly, I would not be concerned about trying them in patients with ILD.
Very good. I guess we don't have any other question. Well, then I would like to conclude. Thank you very much, Professor Strand. That was an excellent presentation. We were so happy actually to have you with us tonight. And I would like actually to thank the audience. And I will put the mic for the next speaker. Thank you very much.
Well, thank you. It was a pleasure being here, even if it was virtually.
Great.
Thank you, Dr. Hassan. See you. Bye.
Bye-bye.
Thank you so much. إبراهيم كيفك؟
اهلا دكتور حسين، كيف حالك؟
حبيبي عساك
كيف
بخير.
امورك؟ الحمد
الله
لله.
الحمد لله. تمام.
لكم ما شاء الله شكلها جميل امس.
الله يخليك الله يخليك يا حبيبي.
يعطيكم الصحة والعافية.
طيب نشوفكم على خير.
الله يحفظك يا دكتور، الله يحفظك.
شكرا دكتور.
عليكم ورحمة الله وبركاته.
Hello.
Good evening, ladies and gentlemen.
Hello. Hello, everybody. I would like to welcome all of you in this session on behalf of Pfizer. And I would like to invite our next speaker, Dr. Osama Haji. He is a senior consultant rheumatologist at Muasat Hospital in Dammam, Saudi Arabia. He is also an associate professor at Ain Shams University in Cairo, Egypt. Dr. Osama is well known to all of us. He is going to talk about non-radiological axial SPA IMPARC trial 2020. So welcome, Dr. Osama.
Thank you, Dr. Ibrahim, and thanks for the great effort of Saudi Society of Rheumatology. This symposium is sponsored by Pfizer. We are a great lucky generation of rheumatologists, as we have a lot to do with the patient who is not idiopathic axial spondyloarthritis. There is no major difference between TNF as a cardiac response, and we are more lucky that we have two IL-17 inhibitors, ixekizumab and secukinumab. But the challenge that we have a guideline, different guideline. We have SS EULAR guideline that 2016, and we have updated of the American College of Rheumatology, Spondylitis Association of America, as part 10, that's published in October 2019. The challenge is this: for the second time in the guidelines era of American College of Rheumatology, they are differentiated into two categories: ankylosing spondylitis, which is radiographic, and non-radiographic, which is the patient is negative for the plain X-ray. And again, they are classified the patient for active and stable or inactive disease. But the most interesting that the advantage of ACR over EULAR, this is the last one here. If the patient is stable, either on biologic or non-steroidal or whatever it is, the chance that we have for ankylosing spondylitis or axial spondyloarthritis, you cannot predict accurately which patient will be with radiographic progression and which one will not be or very plateau. And you can see, and this is a Swiss clinical quality management that published in 2020, there's a major difference between each patient. And depending on the disease duration and symptom, you may have this patient is flat curve. But in general, radiographic axial spondyloarthritis is more progressive than an axial. So when you are with treating non-radiographic axial spondyloarthritis, we should aim to not to over-treatment, not to over-diagnose, and we should be restrict how to prescribe our medicine. And the challenge in tampering, this is a recent publication from Dr. Robert, this published in Annals of Rheumatic Disease. And you can see for certolizumab, this is a clinical relapse between the dose of 200 certolizumab or for every 2 weeks or every 4 weeks, there is no major difference. But if you stop the medication, it means there will be a dropout within 2 months. We are here in the meeting for best of American College of Rheumatology. But for re-embark, it's difficult to be, except that we should mention EULAR and ACR. Why? We have to predict from beginning, early beginning of treatment, which patient will be with sustained response, which patient we can stop the medication, and which patient we can restart the medication. And to understand the re-embark trial, we have to understand first IMPARC trial. IMPARC trial, this is a landmark in the history of non-radiographic axial spondyloarthritis. Why? Because it is the first clinical trial that implements as criteria, not modified New York criteria. That's why it's published in 2014 by Dr. Maxim Douglas. And again, the trial in 2 phases, either placebo control for 12 weeks, then the open label trial that it is ongoing till now. But the challenge is, this is for the first time in the history. We have patients as young as 31.9. It means this is a very interesting early. Not only like this, but disease duration is 2.4. What does it mean? We have a very early patient with non-radiographic axial spondyloarthritis. And you can see that within 2 weeks, there is a split of the curve between placebo and etanercept 50 milligram once weekly for all parameters. But again, for open label, the patient shifting from placebo to etanercept 50 milligram once weekly, it is joining the original curve. So there is no much to lose. That's why non-steroidal, in a practical speaking, will take the lead. If the patient not controlled by 2 non-steroidal anti-inflammatory medication, we can shift to biological, especially high-risk population. But the most interesting for me, and I'm applying this in my daily clinical practice, that not each patient will respond to 2NF, except that the patient with high sensitive CRB and high sensitive or high score of sacroiliac spark baseline value. So if you have a patient with high score of spark baseline value in addition to CRB, this is the best patient that can benefit from TNF. And again, the long-term trial for 48 weeks. That is published again in Annals of Rheumatic Disease in 2016 by Dr. Walter Maximovich. This is a sustained response for 48 weeks. There's no major difference either for the patient sustained, either starting by etanercept or shifting from placebo to etanercept. The most interesting, this is the first publication for re-embark, was accurately in 2019 in the meeting, in the last live meeting. But in 2020, the e-Congress from EULAR, this is the second publication for re-embark. And it was very interesting. By the way, this is a multi-central, open label, 3-period clinical trial. By the way, EMA, European Medical Agency, asked Pfizer to make this clinical trial. Why? The challenge that you have to make a clinical trial with 3 different periods. Period 1, the green one, this is induction, 209 patients treated with etanercept. If the patient is reaching that S-CRP less than 1.3, it means the patient is under control. This patient, you can stop, shift to period 2. The patient stop etanercept for 40 weeks. How many patients respond in period 1? 57 patients reach sustained remission. And again, after 40 weeks of stopping etanercept, you have, if the patient has a relapse, you can retreatment for 12 weeks. What is the response? In general, it is easy to say in period 1, whatever your parameter, either DAS 20, DAS 40, or BAS-DI, or DAS CRP inactive, the last one down, it is, if you are giving treatment, it will be great, then the patient will relapse, then you can start retreatment again. Why this clinical trial is important in daily clinical practice? You may have in the COVID era that you have to stop medication for vaccination, or the patient contact or has a contact with infection or has already infection. What is the value of stopping and restart? By the way, this is the first clinical trial in the history of axial spondyloarthritis that you can stop and restart medication again. What is interesting? What is the proportion of flare after etanercept discontinuation? It is interesting that the patient with as certolizumab, within few weeks, the patient is 22.3. It is end by 67% of the patient has a flare at week 64. So still, there's a 1 out of 4 patient can in sustained remission without etanercept for 40 weeks. And again, the median time to flare, if you are continuing etanercept, the patient will be sustained response. If you stop with re-embark, there is no ESR flare, risk reduction about 85%. So if your patient is controlled, you can continue. Or the patient is remission, you can make off medication. I'm not doing this. I will tell you at the end of my presentation what I'm doing daily clinical practice. But just to summarize this presentation, is the period 1 about 58.7% respond to etanercept, and if you stop 40 for 40 weeks, still 24.8 has in remission. But if you restart again with reactivity, again the patient regain up to 62.1%. To be honest, this is a post hoc analysis, not a randomized control trial. But it is difficult to do with randomized control trial. It is ever difficult to be done. But at least we have to keep this. Yes, it is not randomized clinical trial, placebo control. Yes, it is post hoc analysis. Yes, it is small group. But I think all of us doing this in daily clinical practice. What is interesting in the last meeting, in the last month for ACR meeting, that which patient will have sustained remission status, and what is the relation for re-embark discontinuation or restart treatment? Again, interestingly, that the patient with sustained remission, it is the patient with younger age group, again with positive MRI, again positive CRP, again HLA-B27. So we may conclude from this that the patient with high risk group, this is younger population, high CRP, positive MRI, HLA-B27. If you catch any one of these four, you have to treat aggressive as the disease, in comparison with non-sustained remission patient. So what's the difference? It is, yes, if the patient has sustained the response to standard remission, it is in comparison with a patient with non-sustained response, it is significant difference. But the time flare between both of them, there is no significant difference. What does it mean? Here, again, stop the medication for 40 weeks off medication, remission-free medication. But again, we are not doing this in daily clinical practice. What I'm doing, I make more spacing. If you have available 25, you can decrease the dose. What I'm doing in daily clinical practice, we are making more spacing. We are giving the patient, if sustained the response, sustained the remission, it means at least for 6 months, you can decrease the frequency to shift to 10 weeks, to shift to 2 weeks. I have patients that are taking etanercept for non-radiographic axial spondyloarthritis each month. But again, we should tailor the medication according to the patient response. How many patients has a flare? Interestingly, that the blue one, it is the sustained response. And the red one, it is non-sustained response. What does it mean? If during the treatment, the patient is responding well and sustained response for 6 months, at any time, it is a significant difference. But if you are taking it all, it is about 60% in comparison with 83.7% with non-sustained response. What does it mean? If your patient during treatment has a sustained response, the probability to be an off medication is great. That's why you have the advantage to stop the medication. This is abstract number 1342 from ACR. Again, which patient from beginning you can predict at the baseline, predictor of maintaining inactive disease after etanercept withdrawal and regaining inactive disease status after failure and treatment. The previous abstract about the sustained remission here, it is a baseline. It is presented by Dr. Diodar, Atul Diodar, and this is an abstract number 2028 from ACR. But they are making very interesting univariate analysis. What does it mean? If your patient is high CRB, don't stop because the odd ratio is high for the patient with low CRB or negative CRB. If your patient is positive MRI or high sensitive CRB more than 3, the odd ratio for the response will be not right. This is a period 2. What does it mean? You have to take care about stopping or making spacing of medication in patients with positive CRB and positive MRI. This is univariate analysis. What about the multivariant analysis? For multivariant analysis, again, giving us the support for positive MRI and the high C-reactive protein more than 3, yes or no? If the patient has no CRB or negative CRB, negative MRI, the odd ratio at the baseline will be great. What about predictor? This is the beauty of REEMBARK clinical trial. What is the predictor of regain of inactive disease in period 3? If you remember, I'm sure you are remembering, period 1 on medication, period 2 is off medication for 40 weeks, and period 3 you are giving retreatment for 12 weeks. Which patient is responding well? The male patient. The odd ratio is 6.8, and the younger patient, less than 40, the odd ratio is 7.6. And encephalitis. So if your patient has encephalitis, you have to have resolution of encephalitis before making or sustained remission or tapering or slowing or decreasing the dose, whatever you like to call it. But again, in multivariate analysis, the most important is either male and the younger age population. This is the baseline that the patient, you may stop the medication and the patient regain again the response. What is the pros and cons? Pros and cons for IMPARC and REEMBARK clinical trial is the pros. That is the first clinical trial using in the history of axial spondyloarthritis using as criteria, as we are doing in daily clinical practice. Again, there's 2 different phases. either randomized, then open label, and re-embark with 3 periods, period 1 on medication, period 2, 40 weeks of medication and retreatment. What is the cause of that? It is post hoc analysis. It is difficult to hand. And again, EMA, be a medical agency, asked Pfizer to do this. And I think it gave us a clue that if your patient is younger age with positive CRP, with positive MRI, and HLB27, this is the best patient that can respond. And if the patient has sustained remission, you can make more spacing medication. If you have 25 milligram internal you can decrease. The challenge, can we translate this to other biological treatment? The answer is yes, but we have no clinical trial to prove this as we have for etanercept. So the conclusion of this presentation that we have to try non-steroidal anti-inflammatory medication at least 2 along 1 month, whatever it is. If the patient not responding, you can add biological agent for our clinical trial etanercept, MRI and CRP, especially in younger population and male. Methotrexate has no role except if you are using monoclonal antibody, then you can stop non-steroidal anti-inflammatory and continue with etanercept. By this, thank you for your time and attention, and it is the time now to go back to question and answer. Ibrahim?
Thank you, Dr. Osama. There is one question for you. How could placebo used in a clinical trial for axial SPA, I mean the placebo arm, will be deprived from the medication using the study? Is it ethical?
Yes, it is exactly, as you know, that there is a controversy, great controversy between European Medical Agency and FDA about the non-idiopathic axial spondyloarthritis. That's why before you have a clinical trial with placebo effective for a long time, but at least now it is not in the same age of maturity like rheumatoid arthritis. You have to have a comparison with other medication. That's why the only placebo is only for 3 weeks, for 3 months. This is a very short placebo effect to prove that you have something adding against non-steroidal anti-inflammatory. But it is not ethical to have a long term. Long term, what does it mean? More than 3 months, you cannot do it like this. But the challenge that the patient is not a pure placebo. The patient on a stable dose of non-steroidal anti-inflammatory medication. That's why it is not a pure placebo. That's why it is an advantage to adding TNF to non-steroidal. We can say there's a lot of clinical trials saying that even TNF can be considered as a sparing effect of non-steroidal, decreasing the need of non-steroidal in daily clinical practice.
Thank you very much.
Is another one?
Dr. Osama, there is another questions. Do you believe that there are cases of axial SPA, non-radiological, non-MRI? I think the question about using or diagnosing non-radiological as axial SPA with normal MRI.
The challenge in this, if you're applying, if you remember that SS criteria 2009, they have 2 different arms, either the clinical arm, either radiological arm. For radiological arm, if the patient has MRI finding, so this patient immediately with inflammatory low back pain, right? It's okay. It is this patient is axial non-radiographic axial spondyloarthritis. But if this is a clinical one with HLB27 in addition to 2 clinical parameters, this is a clinical arm. So if you are depending on the criteria, but still, I wish the future will be more bright if the American College of Rheumatology, SS Association, EULAR, and aspartame, they are combining all together criteria. But at least now you can say, yes, we may have patients with non-radiographic axial spondyloarthritis with negative MRI. The challenge for MRI, it is a sensitive tool. It can, bone marrow lesion can happen in normal population, can happen in multipara, can happen in sport injury or sportman. That's why we have to take care not to over-treatment of the patient with non-radiographic axial spondyloarthritis, except the best is younger, the best is positive CRP, the best is MRI, this is the ideal patient to be treated by TNF in addition to non-steroidal anti-inflammatory medication.
Thank you.
I'm on time, Dr. Ibrahim.
Yes.
So it is a yes. It is a great pleasure for me to introduce my dear friend and my dear colleagues, Dr. Ibrahim Al-Hamoud. I can reassure all of you that it will be a fantastic, as usual, from him. Dr. Ibrahim Al-Hamoud is a consultant rheumatologist. He's a chairman of medical specialties department at King Fahd Medical City, as director of rheumatology fellowship in King Fahd Medical City, and he is a vice president of Saudi Society of Internal Medicine. Great to have you, Dr. Ibrahim Al-Hamoud, and he will talk about real-life tofacitinib. In comparison with Dr. Aziz Al-Khalaf, he talked about baricitinib. Now it is a time to talk about tofa in a real-life clinical experience. Welcome, Dr. Ibrahim. The stage, the floor is you.
Thank you very much, Dr. Osama. I would like also to thank Pfizer for inviting me to give this talk about the real-life experience with tofacitinib in rheumatoid arthritis. This is my disclaimer. And as we all know, tofacitinib, it's a band-JAK inhibitor. So it inhibits JAK 1, 2, 3 with similar potency that might give tofacitinib some differences as compared with the other JAK inhibitors. When we talk about tofacitinib, we have to express the wide range of patients who have been exposed to tofacitinib. Tofacitinib has been used in patients with methotrexate naive, in patients with DMARD inadequate response, with methotrexate inadequate response, as well as TNF inhibitor inadequate response. And again, we have to stress on the point that large number of patients have been exposed to this medication. More than 6,100 patients in clinical trial and more than 19,400 patients per year of drug exposure. It is very important to know that, as we said earlier, tofacitinib has been evaluated in one of the most extensive RA clinical development program, as we said, in various populations, because it was the first JAK that got approved for treatment of rheumatoid arthritis. The name of the study was named as oral, either oral start, oral solo, oral sync, oral scan, oral stand, oral strategy, and oral step in patients who failed anti-TNF, as you see in this monitor. Quick look to the result of different studies with regard to control of RA symptoms and signs in patients who were treated with tofacitinib, either monotherapy or as a combination therapy. When we look to the oral solo as monotherapy, is the ACR20 was achieved in 60% of patients as compared to 27% in placebo. When we go into the oral sync, oral scan, and oral stand in patients who are having DMARD or methotrexate inadequate response, we found that the ACR20, it's 52, and it's so obvious the superiority of tofacitinib over the placebo, as you see, ranging between 25 to 31%. And then oral step in patients who have failed TNF before, the ACR20 was achieved in 42% as compared to 24%. Now, when we look to the oral solo as monotherapy, and we look to the ACR20 50-70, as it's so obvious the superiority of tofacitinib over the placebo, the ACR20 was achieved in 60% as compared to 25 at 3 months. And the good thing about the oral solo is that patients who were shifted from placebo to tofacitinib, they also achieved an excellent response, and it showed that the significant improvement with monotherapy, it's sustained up to 6 months, whether we are talking about ACR 20, 50, and 70. This is very important because when we talk about a drug that's effective, we should think about the onset of the action. In 2 different studies, the onset of the action of tofacitinib has been demonstrated to be quick, as early as 2 weeks in a patient with a DMARD inadequate response. Talking about the radiological progression according to the oral scan, as you see, the erosion score and joint space narrowing was reduced in a patient who received tofacitinib as compared to the placebo. So tofacitinib resulted in numerically less progression from baseline in both the erosion score as well as the joint narrowing score at month 6 and 12. This slide, I think, is extremely important because we all now talk about the PROs, the patient-reported outcome. We all understand that controlling the sign and the symptom of rheumatoid arthritis is very important, but also improving the quality of the life, particularly the fatigue and the productivity, is also very, very important to be tackled in management of rheumatoid arthritis patient. As you see here, in almost all the studies of tofacitinib, the PROs, the patient-reported outcomes, including HAC, patient global, patient pain, SF, both physical and mental part, as well as the fatigue by using the FACIT-F score, has been achieved in the studies of tofacitinib. Now, quick look into the strategy trial, which is very important because they used the adalimumab. This study was designed to examine non-inferiority of tofacitinib and methotrexate against adalimumab and methotrexate. And as you see clearly here, the non-inferiority has been met in combination arm of tofacitinib versus the adalimumab and methotrexate. When we look to the tofacitinib monotherapy versus combination tofacitinib and methotrexate was inconclusive, so the primary endpoint of this study was met that demonstrate non-inferiority of combination tofacitinib and methotrexate versus adalimumab and methotrexate. Looking to the ACR response, the ACR 20 in combination methotrexate and tofacitinib has been achieved in 73% of patients as compared to 71% in adalimumab arm, ACR 50, 46 as compared to 44 in adalimumab and methotrexate, and ACR 70 was achieved in tofa and methotrexate arm 25% as compared to 21% in adalimumab and methotrexate. This is just again, and it's so obvious in these figures, the non-inferiority of combination tofacitinib and methotrexate as compared to the adalimumab and methotrexate with regard to ACR 20, 50, and 70. Now, after demonstrating the efficacy of tofacitinib, it's very important to look to the safety. And we have to stress to the point that a large number of patients have been exposed, as we said earlier, to this medication, and more than 34,000 patients per year of drug exposure, more than 200,000 and 8,000 real-world experience, and this reassured about the adverse event where all the adverse events were stable over the time. Looking deep toward the adverse event, more toward the serious infection, just to draw your attention about this meta-analysis, and when we look to the tofacitinib 5 milligram that's approved in rheumatology practice, and look to the RCT, the incidence rate of the serious infection, 2.71 as compared to all the anti-TNF, although it's not head-to-head, but it's very reassuring, and it's almost similar to abatacept, where we all know abatacept carries the lowest risk of the serious infection. And this should reassure all of us about the safety of tofacitinib toward the serious infection. Herpes zoster, which is very important to all of us when we talk about the JAK inhibitors, as you see in this analysis of the herpes zoster incidence rate, just to draw your attention that it's highly variable, depends on the region and countries. And if you look into this analysis, we found that the incidence was higher in the Asian population, in Korean and Japanese, as well as the Indian population. So with regard to the herpes zoster, it's strongly, as you know, associated with decline in cell-mediated immunity. We know the risk is higher in rheumatoid arthritis patients as compared to the general population, but we have to admit that the risk is higher with JAK inhibitors, even higher than the biological agents. But we should keep in our mind that ethnicity play a role with regard to the herpes zoster. It's very obvious that the presence of the Japanese and Korean population in the studies of tofacitinib increase the risk of the herpes zoster. And again, just to draw your attention to the ACR recommendation to vaccinate all rheumatoid arthritis patients before giving the biologic or tofacitinib if it's applicable and available. Now again, just to stress on the point for the studies of tofacitinib that they included wide range of ethnicities, and the Japanese, Korean makes this incident is high toward the herpes zoster infection. When we look to the malignancy, which again very important, as you see in the slide, the tofacitinib was not associated with a new signals toward the malignancy as compared to the other biologics that has been used for quite a long time in treatment of rheumatoid arthritis. It's very important to talk about the major adverse event toward the cardiovascular system, and as you see here, all the tofacitinib doses that has been used, it's the incidence per 100 per year, as you see, is only 0.58, while with adalimumab it's 1.68. That's again very reassuring about the safety of tofacitinib in patients with rheumatoid arthritis. When we talk about the other side effect toward the lipid profile, yes, there is an increase in the LDL, but again also increased in the HDL. So the good thing about this side effect that the increment it's happened and then it becomes plateau over the time, and this is very responsive to the statins. The same story with the neutrophil that might be dropped after the starting of tofacitinib, but the neutrophil count generally stabilized over the time. Now we'll take a look to the real world data, which is again very important for us. And when we look to the Canada, for example, we found that the tofacitinib using of tofacitinib after the one biological agents has been increased. That means the number of using tofacitinib as bio-naive increased with the time. In 2014, there was only 36, and the number is increased significantly in 2016 to be 47%. In their cohort, the majority of the patients reported receiving prior biological demand, and they had a longer disease duration. Approximately 20% of patients receiving tofacitinib were biological naive, and there was a trend for increasing utilizing of tofacitinib in Canada was seen over 2 years of observation. We'll now move to the United States, where there is approximately 1/3 of their patients were bio-naive. And when we look to the adherence to tofacitinib over 6 months was almost 83%, which is almost similar to the adherence rate for biologics that ranging between 81 and 88%. And approximately in their cohort, 50%, half of their patients were using tofacitinib as monotherapy. And there was no differences in adherence between tofacitinib as monotherapy or as a combination therapy. Looking to the safety, in USA real world data. As you see, the serious infection happened in 3.69 as compared to the biological demand 3.29, herpes zoster 1.43 as compared to 0.94. There was no tuberculosis cases in tofacitinib. These data is very assuring, and it's when we look to the data from USA, we found that patients initiating tofacitinib biologics have experienced comparable age and gender adjusted rate of serious infection, cardiovascular events, and malignancies overall. Now we'll move to our cohort in Saudi Arabia in King Fahd Medical City. I have 55 patients, rheumatoid arthritis, started tofacitinib. As we all know, the majority were female, 48 female, 7 were male. Again, we are similar to the other part of the world. Most of our patients, they have established disease. Very few number of patients, they have early disease less than 1 year. The mean disease duration, 6.74 years. A majority of our patients actually were on combination therapy with methotrexate, and only 20% they used tofacitinib as monotherapy. The place of tofacitinib, the majority of our patients have been exposed to biological therapy before using tofacitinib, and I think this is would be similar in almost all, most of the hospitals, because tofacitinib, when it's included initially, your patient has to fail at least 1 or 2 available medication to prescribe tofacitinib. But lately, tofacitinib becomes one of formulary drug in our hospital. So using tofacitinib as the first line of therapy after failure of methotrexate increased recently. And 17 patients, this number has been updated this week. It was much lower, but now we found that me and our colleague in the hospital start to use tofacitinib higher in the treatment algorithm for rheumatoid arthritis. Looking to the previous biologics that have been exposed to our patient, as you see here, almost all the available biologics have been used in those type of patients who are treated with tofacitinib. We used etanercept, tadalumab, tocilizumab as IL-6 inhibitors, rituximab as B-cell depleting agents, and abatacept as T-cell co-stimulatory inhibitors. So all these different biologics have been used before tofacitinib. Talking about discontinuation rate of tofacitinib in our cohort, 14.5% of our patients discontinued tofacitinib, which is equal to 8 out of 55, and almost all of them except one, due to the lack of efficacy. We have only patients discontinue the medication because of side effect. As you see here, almost all of the patients have a well-established disease and have been exposed to different biological therapy before using tofacitinib. When we talk about the safety of tofacitinib in our cohort with regard to the lipid profile, 4 patients developed high LDL. There was no or minor changes in HDL, no changes in triglyceride. There was 3 patients developed low WBCs. As you see, 1 patient dropped WBC from 3.5 to 2.9, second one from 4.5 to 3.8, and the third one from 6 to 2.63, but all of them the absolute neutrophil count above 1. So we don't change the treatment because of this. 2 patients dropped their hemoglobin, one from 11.2 to 9.2, and one from 16.2 to 14.2. There was no drop in platelet count. When we look to the liver function test, there was, as you see here, several patients, they have an increment in the ALT level, but none of them, none of this increment was 3 times above the upper normal limit. So there was no change of tofacitinib therapy based on the elevation of the liver function test. There was no change in the serum creatinine. We have only 1 patient who developed herpes zoster infection. And I would take you to the in details about this patient who developed the herpes zoster infection. This is a 41 years old female patient who has seropositive rheumatoid arthritis for 2 years. She was on methotrexate 17.5 and Enbrel as well as Plaquenil. We saw her in the clinic with a severe disease, as you see, polyarthritis. DAS28 was 6.12, CDI was 24. Her ESR was very high, 101. CRP was elevated, hemoglobin 10.2, and normal renal function and liver function. So we decided to start her in tofacitinib 5 milligram twice daily. We saw her 3 months later. She showed a great improvement. Her CDI dropped to 10, DAS28 dropped to 4.64, and the reason behind that, her ESR still elevated, although it's dropped from 101 to 70, but as you know, this would affect the DAS28. CRB normalized to 1.4. So we continue the treatment. We saw her 5 months later, and at 8 months of starting the treatment, she showed a great improvement. CDI 3 with low disease activity. She has only one tender joint at that time, but there was no swollen joint. DAS28 was 3.44, and that because still her ASR, although it's improved by 50%, but still 50. CRP is 1.6. 9 months after starting tofacitinib, i.e. 1 month after seeing her in the last clinic, she presented to the ER with the herpes zoster infection with 2 dermatome, which mandate stopping the tofacitinib. So we stopped her treatment. She is currently at methotrexate and Plaquenil. So in conclusion, as you see in my presentation, using JAK inhibitor in biological naive patient is increasing, and that's so obvious in Canadian as well as the American and in our cohort. And I think with the time we'll use JAK inhibitor as first line after failure of methotrexate in patients with rheumatoid arthritis more and more. Most of our patients are treated with tofacitinib and methotrexate as combination therapy. We have no experience about combination of tofacitinib with DMARD other than methotrexate. Just to let you know that leflunomide is not available in our hospital, so we have no experience toward this. There was no new safety signals observed in our cohort. And just to take you quickly over the tofacitinib 5 milligram abbreviated prescribing information, as you know, and this is the Zildjian's XR. At this time, I would like to thank you, and now back to Dr. Osama. Thank you very much.
Thank you, Dr. Ibrahim, as usual from your side. I do think in daily practice that this is the advantage that you can use the tofacitinib as a monotherapy, especially that most of our patients is young, in the childbearing period that patient may ask for or planning for conception at any time. And this is the advantage for tofa against or JAK in general against methotrexate and biological therapy, Dr. Ibrahim.
Although we don't have data about the safety of the JAK in pregnancy, I think yes, because they are oral medication. They have short half-life. You could stop it, and after 1 week, you allow your patient to be pregnant. So of course, this is an advantage.
It's not recommended. It's not recommended for during pregnancy, and you have to stop the medication for 2 weeks, and the patient can get conception. In comparison with methotrexate that you have to stop for 3 to 6 months, in comparison with TNF that you have to stop for a few months. Okay.
Thank you.
Yes, this question, is there any difference of JAK inhibitor in terms of the side effect considering selectivity? So it means that do you see any difference between different JAK as regards selectivity or as regard efficacy or as regard adverse effects?
I think this is very tough questions about the safety, whether the selectivity plays a major role in the treatment outcome and the safety for rheumatoid arthritis. Probably, I think the selectivity plays a role in the treatment and the indication, other than rheumatoid arthritis, whether you expand the indication or no for the treatment. So I could say up to this moment, there is no clear answer for this one.
Right. Correct me if I'm wrong. There is no clinical trial up to 18 December 2020 comparing different JAK in a clinical trial. So you cannot say that this one is more effective than the other, right?
There is no head-to-head. There is only the direct adjusted meta-analysis, which is, it has an advantage and disadvantage. It has pros and cons.
Yes. There's a question about the safety of TOFA with renal impairment.
Well, renal impairment, if the GFR is more than 30, you can use the tofacitinib 5 milligram. If it's less than 30, there is no data about the safety of tofacitinib.
We can compare it between bari and TOFA. The metabolism of TOFA is by liver. So if the patient has liver disease, you have to take care about in liver disease. But in renal, it is excreted. So if the patient has mild or moderate renal impairment, you can use it, especially that it's not reaching 30. From 30 to 60, you can use or use the slower dose. Dr. Ibrahim, you agree for this?
Yes, I mean, if it's above 30, you can reduce the dose to be once daily. Below 30, I don't think there is enough data about the safety of tofacitinib.
Please, for Pfizer colleagues, somebody is asking the off-label. It is not allowed to use it in alopecia areata. So it's okay. It's not off-label, although there is a clinical data, but sure, it is not off-label. It is not recommended to be used. Agree?
Yes, it's off-label.
The last one, for how long did you stop the patient medication for herpes zoster?
Well, if the patient developed herpes zoster, this is my own practice. First of all, I have to admit it. I stopped the JAK and I try to avoid the JAK because the risk of recurrence would be higher in those type of patients. And as you know, we don't have the zoster vaccine.
That's okay. That's it. Thank you, Dr. Ibrahim, as usual, and thanks for the Saudi Society of Rheumatology, and thank you for Pfizer for sponsoring our symposium. And go back to the panel. Stay safe and goodbye.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. I wish that you enjoyed the program so far of the official Best of ACR Convergence meeting. Now coming to the last session of tonight, and بالعربي نسميها ختامها مسك for tonight. The very relevant and timely topics, which is COVID-19 in rheumatic diseases. It will be presented by Dr. Siham Al-Rashidi. Most of you know Dr. Siham Al-Rashidi. She's a consultant rheumatologist at Prince Sultan Military Medical Center. She's the program director of internal medicine residence program. She is an active member in Social Society for Rheumatology, and she is the chairperson of Journal Club for the last 2 years. Also, she is a member in the malpractice as well as ethical committee in Bin Sultan Military Hospital. So the microphone for you, Dr. Ziham, and welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank organizing committee and Saudi Society of Rheumatology for inviting me to the Best ACR 2020 Saudi Arabia. I will talk about COVID-19 and rheumatology disease. This is my acknowledgement slide adapted from presentation by Professor Gregener and Dr. Louis given at the ACR Conversions 2020 virtual conference. The learning objectives: to review the global impact of COVID-19 and its effect on rheumatological population, and to discuss COVID-19 outcome related to hospitalization disparity and mortality risk factor in patients with rheumatic disease. And last, to describe recommendation for management of COVID-19 exposure and infection in patients with rheumatic disease. Massive spreading of COVID-19 in different continents have been observed. And using the geographical information system-based map may rapidly analyze changes in epidemiological situation. In this dashboard, COVID-19, hosted by Johns Hopkins by the Center for System and Science and Engineering, illustrating the number of confirmed death and recovery cases of COVID-19 of all affected countries. And as you can see, the number of cases of COVID confirmed cases reach up to 37,800,000 on 13 October at the time of ACR conference. And doubling of the confirmed cases reaching up to 68,800,000 as of December 9, 2020. COVID-19 has variable health impact. In United States, 23,000 confirmed cases per 1 million population, while in New Zealand, only 314 confirmed cases per 1 million population. And this may reflect the difference in government response to COVID-19 between countries, and early banning measure to control COVID infection was appropriate, but still does not fully explain why cases were low in New Zealand. And maybe the only explanation, it was governed by a woman. COVID-19 affect mortality worldwide. There is unprecedented urgency to understand who is at most risk of severe outcome in general population. That's why large database was required. In UK Open Safely study, one of the largest cohort study in UK, aimed to examine the factor associated with COVID-19 related death. And they found that COVID-19 related death is higher with age above 65, being male, and BMI above 30, and more in minor ethnicity with hazard ratio 1.5 for Black and 1.5 for Asians, and also in deprived people hazard ratio of 1.8, as well as associated with comorbidities such as diabetes, non-hematological malignancy, reduced kidney function, and patient with rheumatological disorders such as rheumatoid arthritis and psoriasis. But what about COVID in rheumatology population? There was a particular concern for rheumatologists for patients with rheumatic disease to get more severe infection and subsequent poor outcome, especially they are on immune suppressive therapy and having comorbidity as well. So in response to that, Global Rheumatology Alliance registry was established with the goal to collect data and disseminate the outcome of that registry to help rheumatology physicians to treat and assessing their patient with rheumatic disease and evaluate the risk of infection in patient on immune suppressive therapy. It is a physician-based report registry of patients with rheumatic disease diagnosed with infection with COVID-19. These data were submitted to parallel international data entry portals, one limited to European countries hosted by University of Manchester, the second for all other sites hosted by University of California. And they looking for risk for hospitalization, risk for death, and outcome disparity. So what the risk for hospitalization between March 24 to April 20 for looking main outcome hospitalization, including patient characteristic, age, sex, smoking, rheumatic disease, comorbidities, and medication pre-COVID. And they submitted 600 cases, half of them hospitalized and 9% died. 71% they were female, and rheumatoid arthritis 38%, SLE 14%, and psoriatic arthritis 12%. And the most common comorbidities were hypertension, lung disease, diabetes, and cardiovascular disease. Again, it showed that higher odds of hospitalization with age above 65, with comorbidity, higher glucocorticosteroid, more than 10 milligram per day, while reduced odds of hospitalization in patients on biological DMARDs. The outcome of disparity, 1,324 cases, March 24th to August 26th. It was done in US only, and looking for three main outcomes: hospitalization, ventilatory support, and death, and looking other covariant age, sex, smoking, and rheumatic disease, and rheumatic disease activity, comorbidities, and medication prior to COVID. Again, it showed that minor ethnicity like Black, Latinx, and Asian showed higher odds for hospitalization as well as for ventilatory support, but there was no difference in mortality. Risk for death, again, between 24 March till 1st July, main outcome was death. 3,729 cases were collected, and COVID-19 odds ratio for death was higher with age more than 65, male gender, ever smoke and rheumatoid arthritis, and moderate high dose of disease activity, as well as in patients who were in sulfasalazine, rituximab, moderate dose glucocorticosteroids, and patients who were not on DMARDs. And in summary, this is to show that there is reduced odds ratio of hospitalization in patients on biological DMARDs, higher odds of death with moderate disease activity, higher odds for hospitalization and death in patients on prednisolone above 10 milligram per day. And like general population, higher odds of poor outcome in population with the ethnic minority with rheumatic disease, which advocate to protect racial ethnic minority and reducing risk of infection. And this is the ACR COVID-19 Task Force guidance. Patient with a stable rheumatic disease in the absence of infection may continue ongoing treatment with high to moderate level of consensus. And patient newly diagnosed lupus should start it at full dose when available, and hydroxychloroquine use when available should be continued, and when unable to access, you should switch to a different synthetic DMARDs should be considered. In the context of drug shortage due to COVID-19, the new hydroxychloroquine prescription for non-FDA approved indication should be avoided. The effect of hydroxychloroquine and COVID-19 remain the center of intense debate. In laboratory setting, hydroxychloroquine has shown promising effect by its antiviral activity. At the same time, many discouraging clinical trials raised the safety concern on the use of high-dose hydroxychloroquine in hospitalized patients, especially cardiotoxicity. Parallel to early enthusiasm of the clinical efficacy of hydroxychloroquine, this has dropped and rapidly deflated following the dissemination of the result of large randomized control trials, and FDA revoked its use. So it is not protective, neither effective in patients with rheumatic disease and in SLE, either in prophylaxis, mild early COVID infection, or even moderate and severe COVID-19 infection. The task force guidance for glucocorticosteroid, regardless of the exposure and regardless of the infection status, should be used at lowest dose possible to control disease of the rheumatic disease. Glucocorticosteroid should not be abruptly stopped, and this is a high level of consensus. Glucocorticosteroid and COVID-19. Glucocorticosteroid is the only drug has proven its efficacy in reducing COVID-related death by 1/3 in randomized control trial, and the famous trial Recovery and REMAP-CAP study. What about rituximab and COVID-19? The data are still limited, either harmful and it can cause increased risk of infection or more severe, and even delayed clinical worsening as compared to the classical COVID without rituximab. It may limit the complication of COVID-19, such as cytokine storms, and the patient will present lately, and the difference and the classical worsening is 12 days in COVID-19, while in patients who received rituximab and got COVID-19, the worsening reached up to 21 days to the ICU admission. So it may limit the cytokine storm, but does not efficiently control it. The task force for exposure, hydroxychloroquine, and non-steroidal anti-inflammatory may be continue immune suppressive therapy and non-IL-6 biologics, JAK inhibitor should be stopped temporarily pending negative result or 2 weeks symptom-free, and this is with moderate to high level of consensus. And the conventional DMARDs and infection risk, scoping review, it is an online analysis trying to determine and identify the severity of COVID in patients on DMARDs, which in these studies showed no major safety signals, while in COVID study, sulfasalazine associated with high odds of poor outcome. For biological DMARDs and infection risk, overall may depend on medication class, while in scoping review, more frequent upper respiratory tract infection in randomized control trial of new biologics and high-dose JAK inhibitors. And last, selective biological DMARDs, interleukin-6 and interleukin-1 inhibitors have been used in COVID treatment and need a high-quality interventional trials, but does not show any survival benefit of these medications. Task force guidance for COVID-19 in patient documented or presumptive infection, regardless of COVID severity, hydroxychloroquine may be continued, but others like sulfasalazine, methotrexate, leflunomide, and JAK inhibitor should be stopped or withheld. What about JAK inhibitor and its role on COVID treatment? JAK inhibitors has dual effect as antiviral, preventing the entry of the viral in the epithelial cells, and the other effect being an anti-inflammatory, blocking the pro-inflammatory cytokines, and one of them IL-6, which is attributed to one of the complications of COVID-19, which is cytokines storms. But you have to consider that there is accumulating evidence that COVID-19 is considered a hypercoagulable state by many postulated mechanism and increased risk of thrombosis, arterial and venous. So we have to be very cautious using JAK inhibitor, which is a drug by its own, has a black warning of increased thrombotic effects of this medication. So it may compounding the thrombotic risk with COVID-19. So in summary, for no COVID-19 infection, to continue medication if rheumatic disease under control. For exposure, hold conventional DMARDs other than hydroxychloroquine and sulfasalazine, and to hold biological therapy, other immune suppressive medication while obtaining COVID test. And patient with COVID-19 infection to hold and stop all medication except hydroxychloroquine. Summary and conclusion, patient with rheumatic disease and COVID-19 have a reduced risk of hospitalization with well-controlled disease. However, they should have minimized doses of corticosteroid, since higher doses of corticosteroid equal to higher risk of hospitalization and death. If patient exposed to COVID-19, immune suppressive rheumatological agent should be held while testing is done. If patient positive for COVID-19, all rheumatological agents should be held other than hydroxychloroquine and glucocorticosteroid. As noted above, glucocorticosteroid should be continued at lowest effective dose. And at the end, I would like to thank you all for your patience and listening. Thank you.
Okay. Thank you, Dr. Siham, for the excellent presentation as usual. Very interested. There is a lot of things to be discussed usually in COVID-19, but alhamdulillah, now we have the vaccine, so we don't know where we will be. We have some few questions so far. The first one, do you have, this question is not related to a best of ACR, since the ACR, when it was held, there was no vaccine. And they are asking any recommendation regarding COVID vaccine in patient on biologic, and what about what type of vaccine?
Excellent question. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I think this question, again, it is difficult to answer because we don't know yet about this vaccine per se. It is new in the market, never been used. It is a live vaccine, it is RNA, by itself as a vaccine, there is a lot of debate about efficacy using in normal population. And if we think again about using it in our immune suppressed patient, we have to be very cautious. And even to when you use it, you have to see whether this effective vaccination or not. So the answer, I have no answer for that, but I think the task force recommendation by the ACR will help us, and the guideline by launching and starting this vaccine, it may help in the near future, inshallah.
Yeah, and actually we are, as a Saudi Society for Rheumatology, we are planning to have a task force with infectious disease, and we are already started. Inshallah, I wish within the next maybe 1 month we will have a consensus recommendation regarding the vaccine. It's difficult to say anything now. The other question here, if patient on rituximab and he got COVID-19, so would you continue rituximab or you will shift patient to another medication?
Again, it's excellent, exciting questions. Rituximab, it is a B-cell depleted therapy. So these COVID-19 virus need neutralization of these virus by our natural neutralizing antibodies. And we know that by inhibiting B-cell, you will reduce the effective antibody. And this is, we have again to be cautious. What are the recommendation now is to space patient IV infusion if possible, and to check for their immunoglobulin level. So in a patient with low immunoglobulin level, in patient on rituximab, you have to be very cautious and use it upon indication in case, for example, severe cases or highly required, or you don't have other alternative treatment.
Great. There is one question here about, because we face several cases of RA or any patient with underlying connective tissue diseases, and they said when to restart biological or DMARD therapy or JAK inhibitors after recovering. I mean, patient have COVID-19 and recover or treated. So when you resume the treatment?
I think once the patient is free of symptoms, if he got the infection, at least complete resolution, but by at least 2 weeks. Okay, and again, you have to benefit the risk and risk on such a patient, i.e., if the patient, that they're having active, rheumatological disease, you have to initiate it once the infection is controlled. But again, you have to be very cautious upon initiation, because controlling, as we have said already, that controlling disease activity, it may reduce hospitalization, or the vice versa. High to moderate disease activity is higher risk of death. So we have to control disease and balance benefit and risk.
Yeah, as you mentioned, and the consensus nowadays is 2 weeks post-infection of post-complete recovery. I mean, without any symptoms, is advisable. Again, another question about the vaccine. Did you what would you advise patient to take vaccine? You answered it already, because still we don't have consensus and still early. And the good thing now, they are giving the vaccine to special group for the coming 3 months. So, and this group is mainly age group, those who are above 60 or above 65, and then they will come to the patient with comorbidity. So again, in these patients, it depends type of underlying rheumatic diseases and what treatment they are on and so on. So I think still early to answer this question. Okay, so again, regarding the advice for rituximab, because as from all of the data you mentioned and the publication about the risk of infection is higher mainly in patients with rituximab. That's why most of us, the rheumatologists, and based on this recommendation, we prefer to avoid rituximab nowadays during COVID-19. And if the patient on rituximab, to space it, I mean just to give it, to delay it 3 months or so. If possible, to give another medication, it will be better. Would advise patient, what is here? Again, they're insisting about the vaccine. Here, the dose of dexamethasone is 6 milligram once daily for COVID-19 patient with desaturation. So if a patient with SLE maintained on 5 milligram prednisone and the disease is quiescent, such dose of dexamethasone is equivalent to 40 milligram prednisone. Any comment?
If you want to control the disease upon its use, for example, if the patient having active lupus, if you want to treat glucocorticosteroids in patient with rheumatoid should be used at lowest possible dose as they can. This is the advice. For the of the patient already admitted with severe COVID and maintain on, for example, 5 milligram prednisolone, and he underwent or he go into cytokine storm, you will go by the protocol, as well as it's already for the stress dose for patient with SLE. But again, they may benefit as in the other patient.
Okay, so now the good thing, now we are on time. Thank you all for your presence. Thank you, Siham, for this excellent presentation and discussion. Yeah, coming to the end of the session of the first day, I would like to thank you all for being with us and for your question, for your discussion. We have around 600 plus attendees, and the good thing that they stay with us despite our late at night. So we'll see you inshallah tomorrow evening, the same at 7 o'clock. So be with us, and I would like to thank Anchor, the medical helper with us, as well as we would like to thank all industrial company, Pfizer, AbbVie, Lilly, Novartis, Janssen for supporting this activity. Have a nice night, and thanks a lot. Thank you.
Thank you so much.